Thank you. Hello, everybody. I've been asked to give you 10 commandments on how to reduce the risk of revisions. Now, commandments usually are equal to rules, strict rules to be observed, to follow strictly. But these rules sometimes, as happen like for the 11 exons, become old, so they're bypassed, they're not useless anymore. So I thought to give you 10 remarks on different aspects that might represent food for thought on your daily practice in order to improve and to increase your practice when you're doing a procedure. And in order to, the first thing to reduce the risk of revision, we have to fight and find the cause of revisions. Now, we can divide the causes in two main settings, global settings and personal settings. When we talk about global settings, we know today when we're talking about infection, instability, periprosthetic fracture, wear and osteolysis. So this is the first remark. Follow national and international guidelines. This morning we heard all the symposium on infections. Most of the nations have a national guidelines. If you don't have, or if they're too tricky, just follow some of this kind of articles that give you information and tips and tricks on preoperative prevention, perioperative, or what you do in order to do surgery and how to manage your patient after surgery in order to reduce as much as possible the risk of infections. Second recommendation, second remark, be concise. Don't lose time in surgery. Don't start talking around, don't start playing around. Do your procedure and be concise on your procedure. A third remark would be looking after for instability. Now, my suggestion is to use the largest femoral head available for a given coupling. So if you have a ceramic on ceramic, ceramic on polyethylene, use the largest as much as possible. Actually, 33 is the largest that you need to. After 38, you don't need that much. One thing, that's why I like it very much, is dual mobility. Dual mobility is probably the largest you have it, but one thing, it should be a monoblock. It should be absolutely monolithic, because the difference in terms of sizing between monolithic and modular is significant. So that's why the regional, looking for the regional cemented or uncemented dual mobility, like has been invented and created in France. The fourth remark requires instability. Plan every case, especially the difficult ones, because this will give you the possibility, and as we said before, don't stay only with planning. Just optimize as much, because it gives you the possibility to choose the right component for your patients and position the center rotation and the offsets of your patients as well. Another aspect is, we've already heard before, is instability. Suspect always spinopelvic issues, especially if you see a patient in your outpatient that gives you this kind of x-ray, so with an anterior tilted AP view, which looks like an outlet-like. So suggest and think about a possibility of, especially if it comes with a hyperlordosis, associated with this kind of severe osteophyte around the hip, which is suggestive of His-Pite syndrome, which of course will give you a significant possibility of instability. And unless you don't have high-level devices and technologies like navigation or robotic will give you the possibility to understand exactly the amount of degrees of activation, inclination, and combined activation, then of course the resolution is once again go to do a mobility if you have this kind of suspect. My sixth recommendation is around periprosthetic fracture. Why is this? Because my personal choice is always, when it fits to the patient, to go for short stems, because it's been shown in the literature in a high number of cohorts and with a large number of patients that the percentage of fracture of these stems is very low. Not much, the 12 patients, no less than 1%, as much as my personal experience on 3,000 short stems over 20 years of experience. So use as much as possible short stem in order to reduce the possibility of periprosthetic fracture, particularly if you're in doubt, use cemented. And you can use short cemented stem, because in this case, beside the low incidence, you might face only a C-type fracture that requires no change of the implant, but only internal fixation, and might make the possibility for your patient and yourself much easier. A recommendation, look at where osteolysis. Choose the right diameter and tribology for your patient. So always consider life expectation, level of activity, and decide which is the best for your patients. Ceramic on ceramic, young, active, you can go to ceramic on poly or metal on poly, but only on the elderly patient. When you expect for a patient, of course, a higher level of activity, dual mobility, once again, might be your option, but functional, very high functional requests, you may consider the possibility of resurfacing, but that's a matter of personal love or not, this kind of implant. Another remark, of course, at this point we go to another setting, to personal setting, because nobody of us is perfect. Everybody of us has to improve, can improve its own attitude in performing surgery. So first suggestion, reduce improvisation. Plan your cases, because as we said before on my fourth remarks, you probably will give you the possibility to absolutely get the best position and the best choice for your patient. So which one to plan? Each one, each case. Plan each case. Don't go easily to any kind of surgery, because you will get sometimes very unsatisfied. Personal limits is very important. Balance the difficulties and your skills, your true skills. Don't overdo, because it is understandable that you step out from your comfort zone into a growth zone, which is absolutely understandable and auspicable. Then the farthest step will be getting danger zone. So if you take a longer step, and then you might end like this, and that's very unpleasant for you and for the patient. So try to know your personal limits. Education and continue medical education, enlarge as much as possible your growth zone constantly. Don't lay down, don't become lazy, don't just think you're reaching your point, because that would be probably the worst part of your growth and the worst part of your practice. So in order to reduce risk of revision, it's important to know your patients since the beginning, when it comes into your office and to your, when you start taking analysis from the patients, up to the choice of the implant. But very important is to know yourself, because we have to remind the first single cause of failure for 79% of the cases is a surgeon. So you might be responsible for the first cause of your failure in first person. Training, education experience is very important to continue to improve your surgery. Remember that surgeons performing 6 to 25 procedures have a percentage of revisions double than one performing more than 50%. I want to give you one last remark, which is a bonus out of the 10. Debrief your cases and discuss any mistake you find, because you might get at the end of your procedure satisfied and see that probably everything was going right. But look at X-rays, you might probably find out that your procedure was not that right very much. Thank you very much for your attention.